So I want to thank you for coming. We really, really enjoy and respect our association with UCI Health and the scientists and the doctors and the healthcare providers they bring. So thank you for coming here, and I want to introduce you now to someone who's been with this program from the get-go for over 10 years, Adrian Windsor. Thank you, Adrian.
Jerry's voice really carries. So as he's saying, welcome to Medicine in Our Backyard. This is presented by the Newport Beach Public Library Foundation in partnership with UC Irvine Health. And I am Adrian Windsor. I am a board member emeritus. But I was a part of the founding of Medicine in Our Backyard, and we always like to thank our sustaining supporters of this, Mike and Polly Smith. Polly was actually here last month, so they've been very steadfast for us, and we've kept this going. I also want to acknowledge Kunga and Jane in the back of the room. Kunga's our program director. Jane's with UC Irvine Health. They put this program together for us, and they do such a marvelous job in addressing the issues that most of us have. So Jerry told you all about the summer solstice, but I just want you to know that actually I came up with that idea. And it was because we'd been through the pandemic and people had not been together. And we thought, wouldn't it be wonderful to have an event where we can just bring our members together and get to know each other? And it gives the members a chance to mix and mingle with the foundation board, with some of our major donors, and to get to know each other. And we have wine, we have hors d'oeuvres. We're going to have this wonderful speaker who was very popular during the pandemic with Library Live. He did a presentation of his photography, and everyone absolutely loved it. So if you're not a member, become a member. Kunga will be happy to sign you up, or just go online and do it. Okay. Now, how many of you are members, by the way? Good. All right. Well, the rest of you just jump on board. I hope by May 20th, when we come back here, that you'll all be members. And I'm going to say now, because I might forget it at the end, on May 20th, we have a program on our lower back issues. And Dr. Hashmi, who was here, I think last spring, came on back issues, and he talked about the upper back, and we all had problems with our lower backs. So this time it's going to be lower backs. So that will be on May 20th, and that will be our last Medicine in Our Backyard for the year. Library Live and Witty have already concluded their programs, but if you do become a member, you'll be the first to hear about our next season. So we urge you to do that. All right, so if you haven't silenced your phones, please do that right now. And we will end the evening with Q&A, so hold your questions until the end, and then I'll be coming around with a microphone so that you can ask our speaker tonight. And our speaker tonight is Dr. Emily Blodget. She is a board-certified UCI Health specialist in infectious diseases. Her clinical interests include HIV and AIDS, transplant infection, and infectious diseases. She earned her medical degree from the University College Cork School of Medicine in Cork, Ireland. I expected her to be Irish, but she's from California. She just spent 7 wonderful years in Ireland. She completed a residency in internal medicine at the Icahn School of Medicine at Mount Sinai in New York City, followed by a fellowship in infectious disease from Los Angeles County USC Medical Center. So she's going to be talking to us tonight about antibiotics, myth versus reality. And as I said to her, for those of us who've been sick and been told we can't have antibiotics because they won't work, we want to know why. So please join me in welcoming Dr. Emily Blodget.
All right, thank you very much. Can you hear? All right. So, yeah, I'm gonna tell you why they're probably right when they're not giving you antibiotics when most people ask for it. But we'll start with why it's important. So, what are we talking about in terms of the definition when we say antibiotics? Because it can be a lot of different things. So we talk about germs, and that can include bacteria, that can include viruses, that can include fungi, that can include parasites or worms. It can include any kind of microbe in particular. And so it's what we're talking about when we talk about most infections. But specifically, then we talk about antimicrobials. So those are the medications that we take in order to kill those microbes that are infecting our body. So again, whether that's antibiotic, whether that's an antiviral, an antifungal, an antiparasitic therapy. So specifically, we're talking, though, about bacteria and antibiotics. Those are ones that we think of when we think of antibiotic resistance and what we are struggling with in terms of resistant bacteria that are developing in our bodies. And so specifically, we're talking about the strep throat, the common pneumonia that you talk about if you think about pneumonia, strep pneumonia, if you think about meningitis, for example, that as well. Those are caused by bacteria. Those are the main things, urinary tract infections, all of those mainly caused by bacteria as well. E. coli and the like. So that's really what we're going to focusing. I don't know if any of you saw in the news, but relevant to this talk today is just this morning they are recalling some ground beef that was present because of E. coli that was shipped out in March. So we'll see how that really is relevant to what we're talking about in terms of resistance and why antibiotics given to the animals are really relevant to what affects us as well. And so a lot of people, I just put this in there because a lot of people use the term kind of antimicrobials and antibiotics kind of interchangeably, but really we're talking about one specifically for bacteria and not necessarily for the antifungal or antivirals, but we can develop resistance with that as well. But really, I'm focusing on the antibiotics. All right, so this is just another way of saying it. We have all the antimicrobials are all the medicines that are used to prevent and treat infections caused by microorganisms in humans or animals, even in plants. So these include the antivirals, which is the viruses, which of course the one we think about most is COVID-19 now, but again, flu, common, or we just finished the flu season, but we just went through the flu, chickenpox, shingles. These are what we are talking about in terms of viruses. Then you have parasites, malaria, you can think of, also different worms that are present throughout the country. We see a lot of these these are mainly in children a lot. We'll see it more in common, the parasites in children, and then of course malaria is in other parts of the world, not necessarily the US, but, and then we're talking about antifungals, the fungus, and then we are talking mainly about antibiotics, or another word would be antibacterials. And so these are what we're talking about when we talk about the most common resistance that we can see. And so resistance is what happens when the microorganisms, the bacteria we're trying to fight, actually change or mutate. And then those antibiotics that initially would have worked for them, they don't work for them anymore. So it's kind of the bacteria responding to the antibiotic and trying to evade our own system and our own medication's ability to fight them. So That's what we're going to be talking about here. So it's included, so there are benefits, obviously. You wouldn't be given antibiotics unless there was some sort of benefit to you, but there are risks. How many have GI problems when they take antibiotics? Probably the most common complaint that I hear about, whether that's nausea, vomiting, diarrhea. You can also get other infections that, so for example, our bacteria are important in our gut and in our GU tract to actually keep the balance of microorganisms in check. So there's yeast there, and Candida, which is a type of yeast that's important in order to help digestion or keep our flora normal. So when you take antibiotics, for example, for women, what happens is it kills the bacteria in the vaginal flora that keeps it at bay, so the yeast actually can flourish because it's kind of a balance. But that happens in our gut too, so it's very important that we have that balance. You can get allergic reactions. You can get interactions between drugs. So if you're on 2 drugs at the same time, it can cause a danger because that other drug may be at a very high level, which can be dangerous for the person taking it. And there's ones that are specific to the type of medication. I don't know if you've heard about ciprofloxacin or levofloxacin. Those are antibiotics, and they're associated with specific ruptures of the tendons, particularly the Achilles tendon rupture. And then you have dehydration, which can lead to falls. And then, of course, some, for example, one called doxycycline can lead to a skin reaction and photosensitivity. So you'll get a rash if you go out in the sun when you're on that medication. But one of the other problems is getting resistant bacteria. And so resistant bacteria leads to more and more difficulties and actually more and more deaths in the country as well. So you can see here, it started very soon after antibiotics were developed. So you have Andrew Fleming who developed penicillin in 1941. You can already see that within months, actually, there was already penicillin resistance that was found. And that was only after a few months of therapy. So these bacteria are very, very smart and are able to come up with these methods to evade the killing of themselves. So, and then, of course, you have new antibiotics or different ones that were developed. So methicillin resistant, which is a type of a penicillin that's given. So in 1960 it was introduced, and by 1961 it was reported. You have Staph aureus, which is a common bacteria that's on our skin, and you might have heard of MRSA. Probably many of you have heard of MRSA. So, you know, this is when that MRSA developed. It's been back since the 60s, so for a long period of time. And then other resistance profiles to different antibiotics for different bacteria. So Enterococci, 1992, partial vancomycin resistance. So all of these, you can see very, very quickly when they were developed. So linezolid, for example, is another antibiotic that's new for MRSA. By 2001, it was already developed, resistance to vancomycin, and so it just goes on and on. But it happens quite quickly. But what is important is these spread rapidly. So you can see here the percent of isolates. So this is MRSA here. The red is VRE. The green is fluoroquinolone resistant pneumonia. So you can see how it starts in 1980, 85. So exponentially, these strains are spreading really rapidly. So the number is just increasing. So you see the MRSA, the number of strains, 60%, vancomycin resistant, Enterococcus, fluoroquine resistant. So you can see just over the years, these have exponentially actually increased. And the issue with that is, so, what happens is a lot from this is from travel also as well. And this is what's important. There's a lot of global travel taking place. And so it's not just staying in one area, but it's resistance from different parts of the world that are also presenting. So that's how rapidly, that's why this has been increasingly rapid, is because of the travel and movement of different places. So, so it spreads once they emerge. And this is, again, this is the crux of the matter. So you saw this, sorry. So you saw this going up exponentially, where, look at the number of new antibiotics we have. This is coming down, as you can see. So this is between 83 and 87. This is the amount that we're, this is the big picture, essentially. So at the beginning, the resistant strains are proliferating, right? But new drug development is not keeping pace. The number of new antibiotics has been, dwindling over the last 20 years, and it's difficult to get more drug companies in order to put an interest in their money into antibiotics. Excuse me. The patients are on it for a very short period of time. And when you're on it for a very short period of time, the companies don't make a lot of money from it. So it's not like something that you need to take for, and it costs a lot of money to develop these antibiotics, over years and years. But those resources just aren't there to be spent, So as of 2009, there were only 15 or 16 new antibiotics that were in development, and none had made it to clinical trials. So it's none had against bacteria that were resistant to others. So it's just difficult. So you can see the balance. So we really need to preserve the antibiotics that we have already, because it's not like we're going to be getting many new antibiotics coming down the pipeline anytime soon. So we really need to make sure that we protect the antibiotics that we already have. So one of the most significant challenges, according to WHO and other organizations, is the provision of safe healthcare across the world, and failure of antimicrobials to inhibit or destroy bacteria, parasites, viruses, or fungi for which it has been designed using standard regimens. It's one of the biggest threats to global health. And just to say, more than 2.8 million infections in this country occur from antibiotic-resistant bacteria every year, and more than 35,000 people die as a result of those. So this is not an insignificant amount, and antibiotic resistance also adds $20 billion in excess of direct healthcare costs in the US each year. So this number is not going down in terms of the 35,000 or the 2.8 million infections. And in fact, it's probably increasing over the last few years. This is the most recent data we have, but it is just starting to increase. So really important for us to preserve the antibiotics that we already have working. So how does it happen? So antibiotics and antifungal saves lives, but then they can contribute to the development of resistant germs. Antimicrobial, it's accelerated with the presence of antibiotics and antifungals pressure, right, bacteria and fungi to adapt. And so they pressure them to adapt to evade those symptoms. Antibiotics kill germs that cause infections, but they also kill helpful germs, that's what we were talking about, that protect our body from infection. And antimicrobial resistant germs are the ones that survive and multiply. And these germs have resistance traits that can then spread to other germs as well. So the spread of germs and resistance mechanisms. So germs develop defense strategies against antibiotics. They're very smart. They want to survive as well, just like we do. And antifungals also have the resistance mechanisms. DNA tells the germs how to make these proteins, specific proteins, which determine the germ's resistance mechanisms, right? And so bacteria and fungi carry the genes for many types of resistance. So when already hard to treat germs have a combination of resistance mechanisms, it can make all antibiotics or antifungals ineffective, resulting in untreatable infections. And antimicrobial resistant germs can share their resistance with other germs. That's the important thing too, that initially were never exposed to these antibiotics or antifungals. So, so here you can see we have some, sorry, it's kind of blurry, I think, as well there. Can you all see that as well? Okay, so these are just very different ways that the bacteria can develop resistance as well. Germs change or destroy with enzymes, that proteins that break down the drug. So we have, so they change or destroy the antibiotic. That's one of the most common uses and reasons that we have it. And it also comes from us using these antibiotics as well. So because they are used to the exposure of these antibiotics, they develop enzymes that can evade that and proteins that break down the drug as well faster. So they get rid of, you can have ones that get rid of the antifungal resistance. So Candida, which is the, I'm talking about fungi here, but they produce pumps that get rid of the azoles that are commonly used. So anyway, the important thing is that enzymes are the most important, one of the most important mechanisms that are used to kill the bacteria as well. And you can also change, at the top here, you can see changing the entryways or how the bacteria enters the cell as well. So it can block that. So different gram-negative bacteria that have an outer layer of this protein that helps block it, but it can break down, and so it protects it it protects itself by producing this outer layer that blocks the use of the antibiotic as well. So the other thing I thought was important as well was that where do we use these antibiotics? We think of them in the hospital, right? But actually, most of them are used, you can see here, livestock. As you can see here, that's where most of the antibiotics are used, actually. Whereas the crops, very small amount, pets, small amounts, and then the aquaculture, small amount, and then humans. But as you can see, that's how much is used, okay? And so if you see these here, you also, in combination with this, when you're looking at the humans, it's general practice. So it's those going in to their GP, going into the urgent care. Those are the ones that are the most common, followed by the hospital inpatient and hospital outpatient and other communities and dentists. But majority, and this is seen if you're looking between 2014 all the way to 2018, it's been about the same. So really what we want to focus on when we're looking at the antibiotics, particularly with humans, is the community. It's out there in the community when you go to your doctor and you see them say you have sore throat or you have a cough or you have runny nose, all of those, you know, asking for an antibiotic. Well, this is where most of it comes, but probably it's less likely to be necessary. Most of those symptoms are caused by viruses, which aren't affected by the antibiotics at all, but we'll talk about that. So this is looking at the antibiotic prescriptions. population by state. So you can see here among the highest, right? So we have California here. We have all these others, but these are, can you see this? So we're among the better ones, the lower ones here, but goes all the way, you can see here in this area as well. You can see how many prescriptions there are. So very, very big practices, but are these appropriate? And that's the question. So in 2014, there were 266.1 million courses of antibiotics that were dispensed to outpatients. And again, these are the major community pharmacies that are sent. At least 28% of those that were prescribed in the outpatient setting was thought of to be unnecessary reserved, so quite a few. So the total inappropriate antibiotic use, which means, okay, so it increased when they talked about if you were given the wrong antibiotic for what they were treating to begin with. So say, for example, you had a urinary tract infection, but they gave you an antibiotic that usually is used for a pneumonia, say, for example. So if you include that, if you include the wrong dosing and then the wrong duration, this is another thing that's important. We're learning more and more that you probably don't need the long duration of antibiotics that we initially thought. Probably shorter is better. Probably you don't need that long now. So for example, we used to give 7 days, 2 weeks for urinary tract infections, just simple bladder infections. Well, now we think 3 days is probably enough. So we're learning more and more. But the important thing is they were unnecessary and then inappropriate in about half of the cases. So they were just given the wrong thing. And then 80–90% of the volume of human antibiotic use, again, occurs in the outpatient setting. So really it is when you're going into your GP, into your primary care doctor, your internal medicine doctor, that's what's important. So the other important thing is how, so we just need to be aware of the appropriateness, but the other thing we need to be aware of, so how germs can spread in the community, right? So it's not just you're getting antibiotics, but it spreads. And one of the things we talk about is from food to people and between people and animals. So this is why it's really important to have hand hygiene. So, there's other infections too, but, they can spread through sexually transmitted infections or, and it's just another one that's important because it's getting more resistant. That's why it's talked about. But again, spread from food to people as well. That's what's important. That's why we see some in the community. And so community-associated infections, they happen, people who are otherwise healthy, who have not had any interaction with healthcare-associated germs, but they can get resistant bacteria too. And so they're not the ones because the healthcare-associated germs in particular tend to affect the sicker, more vulnerable patient populations. But because of that, infections in the community can be difficult to identify and control the spread. In the hospital setting, we're sending a lot of cultures. We're following these patients. We're seeing what the resistance profile looks like. In the community, we don't necessarily see that at all. And so mobile new forms of resistance can emerge and spread quickly because we're not keeping abreast of all these in the community. So, and they can share their resistance genes with other germs. So it's all kind of part of it in the community because they are interacting with other germs as well out there in the community. So this is just showing examples of how it occurs. So you have here in the middle, but you starts with the food. So what happens is the antibiotics that they're given in their food can occur, and so we are actually taking them in and eating them. And so also you can see that's one of the more common reasons we see these in the community. So it's contaminated in the food, it comes to us, we get it in our intestines, and then it can spread through that as well. So, and then here we also have it when you're going in and out of the hospital as well. So you go to the hospital and then you're coming into healthcare facilities, you get resistant bacteria, but then you're going home and you're spreading it to other people that you are interacting with when you're home as well. So just need to be cognizant of that as well. So for example, when you're in the hospital and have certain infections, we tell you what those infections are if you've been screened for it and if you found to have resistant bacteria. So you know that when you go home, there could be a risk that you have, or that you will be spreading that to other people. Now, most of these very readily controlled with just hand hygiene, washing your hands and all that, but it's just important to remember most people don't want to spread it to their family as well. So this is, we get it here, the resistant bacteria spread to the patients, and it's not just, so that's why we're really cognizant of cleaning all the surfaces in the hospital as well. So then when you're touching it, and then you go home, you're not spreading it to other people as well. And so this is just another example of it. We're just talking about the same thing here. We're talking about food, getting into our, into people, but also when they're going into the hospital and then they go back home as well. This is just another one I'm talking about the alternatives to antibiotics. So because it's important though, because we have a lot of antibiotic use in feeds. So a lot of feeding in animal husbandry develops the multi-drug resistant pathogens in these, and then they go on to human. But we do have some alternatives looking at, and those may be used to animals as well, called bacteriophages in particular, which are viruses that actually can be targeting certain bacteria as well. That's the one that probably is the most, that we've seen the most success with as well. So when we have these multi-drug resistant bacteria, so you can get it. So it's really important to wash your hands from handling or eating meat, seafood, milk, or eggs that are raw or undercooked, contaminated with these resistant germs. Handling or eating fruits and vegetables contaminated with these resistant germs. Contact with untreated or uncomposted animal waste as well, either directly or when it gets into the water in the environment, and then touching or caring for animals without proper hand washing. So again, all this is not to scare you. It's very easy to control these with just proper hand hygiene. It's just really important. It's like we talked about with COVID too, just important to wash your hands. Well, that'll be really important when you're food handling as well. Very, very important. Again, livestock and poultry producers protect people and animals. It's important so they're not giving too many antibiotics, so there's not antimicrobial resistance as well. So again, clean, separate, cook, chill, 4 steps to safety. That's important to control any spread of the infection as well. So the other new thing is just showing how we need to prioritize different antibiotics for different organisms. So these are the ones that are critical, high, and then medium priority as well. So these are carbapenem resistant, Acinetobacter. These are ones, and Pseudomonas aeruginosa. These are ones that are most commonly seen in hospital setting, but we are seeing these more and more in patients coming from the community, that it's really important. The carbapenem resistant for all of these as well. And then you have vancomycin resistant, enterococcus. We see all the penicillin resistant, vancomycin resistant Staph aureus. So all of these are very important to think of. But this is just giving you an idea. This is something else that's important. Wash your hands. Ask questions. So what that means is when you are going to your physician, ask them, do I really need this antibiotic? Because a lot of physicians, we just think that that's what people expect to get when they go to the physician, is just to get an antibiotic, but that may not be the answer. So ask questions, and ask questions of your doctor and say, is that really important? Never share or use your leftover antibiotics. It's important to take the course that you were given. So you need to, if you were given 5 days worth, finish all those 5 days worth. Don't say, oh, I got better after taking it in 1 or 2 days, and so I don't need to continue it. But not a good idea. So finish it as it was prescribed, and then don't give it to someone else. Just say, oh, I have some left over. Do you want to take it? You probably need it. Not a good idea. And that's how some of this resistance spreads as well. And again, talking just about preparing food as well. And so what can we do? Again, prepare food safely, improve antibiotic use. What that means is going back to asking questions. Is it important? Is it necessary that I take antibiotics? Is it something that is going to be helpful to me? Again, hand hygiene and just being active. And also, it's important to get your vaccines also, so to help with the resistance. For example, your pneumonia vaccine, very important, because the vaccine prevents a lot of resistant pneumonia as well. It's been engineered to help with that as well, and based on the genetics of it. So it's very important. So updating on your vaccines really can help with that as well, because there's less, for example, less pneumonia circulating. Because you've been vaccinated and protected, it kind of stops it from spreading as well. So these are very important. To be active in what you guys can do yourself to stop antimicrobial resistance. And that's it. I think we have time for questions now, right?
Great, thank you, Dr. Blodget. So, yes.
The first one. Hi. I have actually 3 questions. One of them, about 30 years ago, I was in a hospital and I had a reaction to penicillin. Mm-hmm. I hardly remember what it was, maybe a red rash. So since then, I have always said I am allergic to. Now, can one try it again? Because it's very difficult to find antibiotics, in a non-penicillin avenue. So what could be the worst thing if I try again a penicillin based antibiotic?
So the most important, and we get this a lot because patients come in and they have a list of allergic reactions this long, but actually many of those are not allergic reactions necessarily. Some say, oh, my stomach was upset, or rashes. That can happen. It's really breathing. If you're having any breathing difficulties at the time that you get it, that immediate reaction, that's the important one. And that's the one that's the most dangerous to give. If you just had a little rash that happened sometimes what we do, if it's the best thing for you still, is give you medication to treat the rash while you're finishing your antibiotics. Because most of those happen after you've been on antibiotics for some time, meaning days to weeks if you need to be on it for a long time. Those will happen later on. They're not at the time. If they happen at the time that you first get it, that's very dangerous and you don't want to try that again. But many of these happen, they're a little rash, they happened a few weeks. You probably could try those again. We do that a lot in the hospitalized setting. What we do is send you to an allergist and you get a graded amount of the penicillin
and see the
reaction. But it's good because then it's not a problem and you can take it the next time. So, because it's really important to have all the options, as you can see. We have very, very few options, and so to close that off is very dangerous.
So my other question is, I have an immune deficiency, and also like they try to always give me antibiotic when I have,
Yes.
and I am very conservative in that department.
Yeah.
So how do I monitor myself to say, you know what, I think I need an antibiotic, or no, this isn't it? What would be some of the red flags that you know, this would be a good idea to take antibiotics?
Right.
With your own body?
So one of those, if you're speaking most commonly about upper respiratory tract infections, runny nose, sore throat, is that what you're talking about in particular?
Well, I have like sinus
Yeah.
and then
So mainly with that is duration. If those happen and it stays for about days to a week, 5 to 7 days, probably is too long, and that you do need an antibiotic at that time. A lot of times people just get it after a few days, it goes away, and they don't need it. But if it stays and you get it for 7 days or so, then it probably is time that you need to get an antibiotic. So I kind of look at that in terms of how long have you been sick.
And then my third question is, you go to the doctor, you go to the outpatient clinic when you have something, and everybody gives you a different name or a different prescription of an antibiotic. Now, how do we know which one is the right one? I mean, is there a way to look it up, or?
So yes, you can. I mean, really, I don't recommend Dr. Google all the time, but you can look up some of those as well. In those, you mean that different antibiotic names? Are they the same?
Give you one, and then you go to your real doctor. You go, no, you're supposed to be taking this. So you don't trust any of it anymore.
Right. A lot of that, unfortunately, is what physicians are comfortable with too. They're familiar with certain antibiotics, and that's their go-to that they give. But the CDC on their website for particular types of symptoms, they have very good recommendations in terms of which antibiotics for which types of symptoms are recommended as well.
Okay, thank you.
Yeah.
Thank you, Adrienne. Hi. Thank you so much, Dr. Blodget.
Yeah.
This is really interesting. Do we have an idea of what the human toll of antibiotic resistance is?
So we do in the U.S., we do about, like I said, in terms of there's about 3 million infections a year that are due to resistant bacteria. That ends up being tens of thousands of lives that end up dead. So 35,000 to 40,000 deaths are attributable to resistant bacteria. And then in terms of that, that's billions of dollars as well in healthcare costs, because they need to stay in the hospital longer. They require, so when you get to those antibiotics that are for more and more resistant bacteria, more expensive to give, they end up being thousands of dollars a day. You also require IV therapy, and so you can't just take that tablet at home. So there's, many costs of living not cost of living, but,
Expense.
yeah, you're not going to work those days as well. So it's billions in terms of that. And then lives is about 35 to 40,000. Yeah.
Thank you. And then when we're in the community, obviously, hand hygiene is important. So we're at the grocery store. Do we use those antibacterial wipes, or
Oh, yeah,
that
you
they
can
provide?
use those on the hands.
Or that
you
doesn't.
can use,
I
know they have
sometimes
hand
hear that kind
sanitizer.
of contributes to the problem.
They're different though, no.
Okay.
Yeah, no. You use those hand sanitizers, they have some in the back too, I think. I still use them, for sure. It's important.
Hi, this has been very interesting. Could you speak at all about the government regulations about the use of antibiotics in poultry and livestock?
Yeah, so I know that they have been trying to limit that. I know there's actually Congress, it goes before Congress a lot too, that they try to Yeah, regulate the types and the number of antibiotics that they're given. Unfortunately, I know many of the, meat producers in the country also have a very big lobby. So they can spend a lot of money to try and limit that, because for them, it saves them money, because, right, they don't have to lose as many of their livestock or chickens or any of those. So yes, it is, but it's really an important cause of resistance that spreads. So many people who never have been exposed to certain antibiotics at all get de novo or new infections with all of these resistant bacteria, that it just doesn't make sense that they haven't been in the hospital, they haven't even been exposed. So we're learning more and more that a lot of this can be due to the exposure with food. That's why it's important, to regulate that. It's starting to get more. As you can see, there's a lot more available now for antibiotic-free, right? In terms
Right,
of the meat, I think they know that it's getting to be more important to people, and that people are looking for that specifically, to antibiotic-free, hormone-free, any of those. Yeah.
Thank you. On that line, does it matter if your gut health is good and you're protecting that? Will that help combat then the antibiotics that are used in the livestock?
Right. So yes, it can. If you give, in terms of your gut health with probiotics and things like that. So the probiotics are most helpful when you're taking antibiotics yourself, because then it kills those bacteria. And so the probiotic helps build that good bacteria back up. So it's most important when you're on antibiotics yourself, that's killing the quote unquote good bacteria as well as the bad bacteria. So in terms of that, though, it won't protect you from being exposed to that resistant bacteria in the first place.
So from the livestock then, there's not much that you can combat?
Well, I mean, cook it well, right? If you're cooking it very well, if you're washing your hands, all of those help. But yes, it can be limited, because it can just be when they're actually butchering the animal too, they have to, some of the intestines that they have leak into the meat. And so that's what happens. So it's important just to cook it so you kill all those bacteria, and then wash your hands as well.
May I ask a second one? Internationally, do other nations use antibiotics in their livestock as much as in the States?
Yeah, Europe, I know for sure Europe, they don't use the amount of antibiotics that we use in our feed at all. The other thing is too, at least here in this country, we have very limited, so there are very few meat producers for different things throughout the country. They're all kind of owned by a lot of the same groups as well, kind of a monopoly, if you will. So they all kind of have the same risks that have it. But in Europe, though, they don't use the antibiotics that we do at all, for sure.
So just going back to the probiotics, I have noticed whenever going to a physician, whether for myself, my children, whatever, that their number one thing they want to do is just throw you an antibiotic and get you out of their office. So
Right.
it seems like it's the quick turnover more than it is, let's dig
Figure out
deep into what's really happening here.
Yeah.
So how has the medical community mitigated that problem with its own physicians, doing that? I know that urgent care is like that. General GPs are also like that as well. So that's been my experience. But also, how come not one physician has ever said, take probiotics since I'm giving you antibiotics? Because I know that personally, but when I tell my friends, they're like, my doctor never told me that.
Right. We're not very savvy when it comes to those that are not. It's not, the problem is, in terms of probiotics, it's not taught in medical school.
Why do you think that is?
Good question. I don't know, to be honest. I mean, it's not, I guess part of it too is that there hasn't been a lot of randomized controlled trials, a lot of evidence for years that they've done it. They're relatively newer use, so we're starting to get more information on it, but I think it's just not taught in medical school. I think in terms of antibiotic resistance, we're learning a lot more about that now, and our students and that come in and are training with me now very much more aware. But I think it goes back to a few things. Like you said, one, we as doctors assume that you're coming in asking for an antibiotic, which is not necessarily the case. But I think that's how the thought process is, just being honest. They think, oh, and also, like you said, it's the easiest way to turn over the room and just get
So,
you.
but how has the medical community tried to resolve that problem? Have they even tried to resolve that problem?
Not like we should. I know that we are, in terms of the medical, getting CME, continuing medical education, at least within UCI, teaching people about this, like resistance as well, on another level. So with our continuing education, that's what we're trying to do. But fundamentally, and I do it when I teach the medical students, because I teach the first and second years as well. So it's just starting to get that into their minds. But when they go also in our shadowing physicians as well, once they're getting the practice, it's, it can be difficult because that's what they're seeing a lot. And so that's what they presume is the right thing to do when it's not necessarily the case. So
Yeah, so.
it just goes back to education. I think we just need to focus on that with the new young doctors that are coming up.
Do you think that that will ever be something that transpires in the future?
Oh, I think so, because you saw the list, the number of resistant bugs and the number of bacteria. It's going to come to a point where we're not going to have that many options. So we're going to have to learn how to preserve all of those that we can, and it's going to come back and say, no, we just can't give you these antibiotics because we don't think it's necessary at this time. I think it will.
What do you, on that note, what is your take on doing natural antibiotics like garlic and so on? Do we know anything of that being helpful?
I mean, I know that in terms of our own, I would say specifically for viral infections, I think there's a lot of evidence with vitamin C, zinc, those type of compounds too. If you have a bacteria, not so much. You just need to have the
Okay, but
antibiotic.
viral,
But viral, definitely. Vitamin C, I recommend. Also, for example, though, to your point as well, if you have recurrent UTIs, there are certain things like D-mannose is another compound that's helpful to prevent that. It makes changes the urine so that it's inhospitable for bacteria. So if you have the recurrent UTI, then it helps. It just makes it so that the bacteria won't survive. So certain things, but in terms of viral, the vitamin C and zinc for sure.
Could you say that word again? D-mannose?
D-mannose, M-A-N-N-O-S-E.
Somebody over here?
Hi. I have two questions. How critical are the antibiotics for any surgical procedures?
How what?
Any surgeries people go for, how critical are to give the antibiotics up to the procedure?
Well, so what I would say is, because that's where I would focus on the fact that most of what we're talking about is in the outpatient setting. Mm-hmm. It's in the community, but yes, in terms of it really did giving that one dose, whereas it can be a risk of certain diarrhea and other side effects. It does help prevent those infections later on specifically. So they are critical for certain types, for certain types of procedures that can be what we call quote unquote not necessarily clean procedures. Maybe you're going into the abdomen, you're going into an infected area. So those are very important because otherwise you're going to end up using antibiotics for a longer period of time because an infection will happen. So
The second question is to piggyback on this one. Like antibiotics, physicians get the samples or they promote those antibiotics. Probiotics are over the counter most of the time.
Yeah.
Is that the reason they don't even talk about probiotics because they're
I
not?
think it's just they're not that familiar with it, honestly. There are a lot of different ones. I know people ask me, which ones do you approve? There are so many that are out there. It's hard to know what to approve, and so I just feel it's a lack of knowledge and familiarity. I think that's the main reason why it's not. And to your point about samples, well, we don't do samples at UCI, so it's just not something that we do, but that's not the same in the community. But most of them are very cheap now. They're generic, a lot of these antibiotics as well. So it's not like they necessarily get any kind of, they're not coming to, or their drug reps aren't coming to see them for the most common antibiotics that you get. So I think it's more to do with what she's saying in terms of what's the fastest way to get someone in and out of the office. I think it's more to do with that than anyone coming to see them trying to promote the antibiotic. Because as you saw, the number of new antibiotics is like this, and particularly for tablets that they would give in the community. So
What's the difference between prebiotics and probiotics?
Oh, so the prebiotics can get altered in your body and in the gut to the probiotics as well. So it's just like another step that has to go through.
It's like the fertilizer to the probiotic.
Yeah.
So has there been any research or studies on the overuse or overprescribed antibiotics in relation to mental health? Because I had a family member who had a baby and then wound up with C. diff, and they treated it with 3 rounds of really heavy antibiotics, antifungals, whatever it is.
Yeah.
And then they ended up doing a fecal transplant.
Yeah.
Which resulted in SIBO, which resulted in more antibiotics, and to this day she's still not okay, but every time she would go to the doctor, she would be depressed, all these symptoms, and I just thought, like, at what point are we now destroying the mental health of somebody via the gut, through the vagus nerve, connection?
Right. I have not seen a lot of data on that. There's more like anecdotal and just individual cases and things like that, but nothing on a large level. Mostly what we're talking about in terms of the large level is the appropriateness of even giving the antibiotic. And as you saw, about a third wasn't even appropriate that they were giving.
One quick question. How effective is yogurt in terms of being a probiotic?
So there are certain ones that have a higher level of probiotic in them. And so those do. They are effective, but the more effective are the ones that you can see in the capsules. But they do have some, just because the ones in the capsules have a higher level of the probiotic in it as opposed to the yogurts.
So we should read labels.
Yeah.
Okay, any more questions? All right, well, thank you so much,
Thank
Dr.
you.
Blodget.
Great
We
questions. Thank you.
appreciate your coming tonight, and come back on May 20th. We'll be working on our lower backs, so have a good evening.